Welcome to this series of interviews with the giants of cardiothoracic surgery. My name is Leanne Harling and I'm here at the Institute for Global Health Innovation with Professor Darzi. Professor Darzi holds the Paul Hamlin Chair of Surgery at Imperial College London, the Royal Marsden Hospital and the Institute for Cancer Research. He is Director of the Institute for Global Health Innovation and Chair of Imperial College Health Partners. He is also a Senior Consultant Colorectal Surgeon at Imperial College Healthcare NHS Trust. Professor Darzi leads a diverse range of surgical research, directed towards achieving the best surgical practice through innovation, evidence-based medicine, enhancing patient safety and healthcare quality. His contribution to surgical research has been outstanding, and he has published over 1,000 peer-reviewed publications. In recognition of these achievements, Professor Darzi was elected as a Fellow of the Royal Academy of Engineering, a Fellow of the Academy of Medical Sciences, and a Fellow of the Royal Society. Professor Darzi was knighted for his services to medicine and surgery in 2002. In 2007, he was introduced to the House of Lords as the Lord Darzi of Denham and appointed Parliamentary Under-Secretary of State for the Department of Health. Upon relinquishing this role in 2009, Professor Darzi sat as the Global Ambassador for Health and Life Sciences until March 2013 and currently remains a member of Her Majesty's Most Honourable Privy Council. Throughout his clinical, research and political career, Professor Darzi has dedicated himself to the pursuit of the highest possible quality healthcare. His contributions to global health policy have undoubtedly shaped the future of healthcare and will do for years to come. And his advances in surgical training and innovation provide an exciting platform on which to build the future of surgical innovation. Professor Darzi, thank you for taking the time to speak with us today.
Pleasure.
I wonder if we could begin by discussing how the challenges faced by healthcare today differ from those of previous decades and how you feel this may change in the future.
Sure. Well, healthcare remains a very exciting area in terms of innovation. And I think the main driver for that is, as you pointed out, is the changing the whole challenges that face most healthcare systems. You know, from the era of infectious disease, the biggest challenge facing us at the moment, or the biggest burden of disease, is chronic disease, which is mostly related to lifestyle disease, illnesses. Obesity would be a good example of that. Chronic disease, in terms of what used to be acute and lethal in the past, is chronic and you live with. Cancer would be a very good example. The economic climate in which we deliver healthcare is even more challenging. So if you really look at all the challenges, they are very different from the past, but at the same time, the solutions are not dissimilar. In other words, we're looking for innovative solutions to address some of these challenges, which essentially boils down to how do you improve quality, how do you improve access, and how do you actually improve the cost effectiveness of care.
Thank you. And looking at surgery specifically, what do you think are the key factors in providing an environment to encourage surgical innovation?
Surgery is an area, historically, we've seen a lot of innovations in actual fact, as surgeons, or the surgical discipline has disrupted itself historically, either through introduction of new medicines, which has really made surgery obsolete. A good example would have been in the 1970s, where H2 antagonists or proton pump inhibitors were introduced, and the whole era or generation of surgeons doing gastrectomies for peptic ulcer disease was completely wiped off. We saw a similar revolution in my time in laparoscopic surgery, where complete mindset change from the bigger the incision, the better surgeon you were, into tiny incisions, so-called keyhole surgery or even robotic surgery, and really has transformed the whole face of surgery from very long, prolonged in-hospital stay to more day case procedure, through which we've improved access, we improved quality, but at the same time we've reduced cost. And surgery will continue to innovate either through new technologies, new devices, or re-engineering the whole process or the pathways of care, or even some business models when it comes to delivering surgical care. And we've seen examples of that, for example, in surgery centers or ambulatory care centers, where surgery is done in a much more in an environment that will actually allow us to innovate in planned care and separating that from acute care, in which you cannot really plan.
And you were saying about infrastructure considerations. I know there's an increasing drive to involving patients in our surgical practice and patient public engagement. What do you think is the role of crowdsourcing and involving the public in future surgical healthcare policy and surgical innovation strategies?
Well, no service, if you just think about outside healthcare, no service will ever survive out in the marketplace if you don't talk to the customers using that service. And I don't see any difference when it comes to healthcare. Patients have a huge amount to contribute. In actual fact, when it comes to innovation, patients have identified the areas in which we can innovate. So talking to the patients is an extremely important part when you are really reforming any pathway of care, whether that happens to be a surgical one or even a non-surgical one. In terms of the public, that's a very different category. Public tend to get most of their information from the media, so they tend to get the headline news, whatever that happens to be. But I think clinicians, no different than scientists, have to have the right platforms in which they engage the public, explain what change means and what quality means in healthcare. You know, I famously said quality is a moving target. So unless you really engage with the public and explain why stroke services have to change, as we did in London many years ago, you will get resistance, because most people see health and provision of health as their health security. So if you're going to tinker around and change a service without actually empowering the public, why are you making those changes? You're not going to get anywhere. And history is littered with examples of reform done for good reasons, but done very badly because they haven't really engaged the public or the patients.
Absolutely. And perhaps even in the surgical forum with trying to develop robotic technologies is a similar thing, in that certain specialties, particularly in cardiothoracics, I think we find that there's some resistance to moving towards a more minimally invasive approach and robotic approach. What do you think are the main barriers to adoption in developing robotic technologies in surgical practice, and those specialties that are becoming still a little resistant to that kind of technology?
The adoption and diffusion of innovation is challenging, but there's always another side to it. You need to make sure that no one is adopting and diffusing innovation that doesn't create value, whether that's a health value or economic value. So I'm not going to be critical of people who haven't taken, but if you have the evidence base and you have a very clear set of guidelines in terms of the commissioner and the payer of a service, then you need to make sure you have the right necessary tools and environments to allow that adoption and diffusion to happen. And we've looked at this in great detail. There are a number of enablers which we know what they are. Things like investment in research and development. So organizations like Imperial gets huge sums of money to really drive that the invention cycle and the innovations through. But at the same time, I think what we picked up, which is even more interesting, is what we call the cultural dynamics in an organization. You can go to an organization and you see within 5 minutes of walking in that they are innovative in everything they do. It doesn't have to be surgery. It has to be even the way they cater for their patients in terms of their food. And you can go to their organization, they don't have that. And these cultural dynamics are extremely important. What's the leadership in that organization? What's the leadership of the board of that organization? Are they really driving that innovative culture? Do clinicians have permission to take risk? Innovation is also about risk. It has to be a calculated risk, but do they feel that they have the permission? Do they feel they have the permission to fail? Because in many innovations you actually fail, and are you going to be punished for that? Do they have the time to start thinking rather than constantly chasing their tail in terms of fulfilling whatever that duty happens to be on the day? So you really need to look at all of these cultural dynamics at a team level, at a ward level, at a hospital level, to make sure that the organization has the right environment, the right culture in driving innovation through. That is the most powerful way of increasing the adoption and diffusion of evidence-based innovations that create value. You can't do it on an individual basis. You can't go to the cardiac surgeon and say, you better do this because I think it's better. It just doesn't work.
Interesting that you say about providing an environment in which it's okay not to be, from the beginning, achieving maybe the same kind of outcomes in the terms of speed of service and how do you think that things such as with robotics, learning curve cases kind of factor into that? Because I know there's a lot of concern about the initial learning curve and the role of simulation in developing that to reduce that learning curve.
Well, you keep asking about robotics. Robotics is very close to me. I've done a huge amount of research on robotics. We have the Hamlin Center, as you're well aware of that. But it's important to come back to the point. Innovation is whatever you introduce, it has to be able to demonstrate that it's generating value, whether that is a health value or an economic value. So far, 10, 15 years down the line, there hasn't been one scientific publication that has actually demonstrated that robotics does create value. So that doesn't mean it would not. That means whatever we're doing at the moment needs considerable improvement before that is really ready for diffusion innovation. So I'm not going to be critical for people not doing robotic cardiac surgery because I think the evidence base out there doesn't really demonstrate. I'm not, cardiothoracic surgery is not my personal expertise, but even in other areas, it doesn't really demonstrate that it's generated value. But that means that further work needs to be done in refining that technology. Further work maybe need to be done in training of the people using it, or even redefining the criteria in which you use technology like this. You have to remember, technology is a mean to an end. A robot is a mean to an end. It cannot be an end in itself. Once you have that mindset, you're not going to do the right thing.
And you say about training, how do you think that we can integrate innovation into training when we've got increasingly reduced working hours, European Working Time Directive, etc.? How do you think that we can best kind of foster that training?
Well, you mentioned European Working Time Directive, and I've heard this all over again in terms of changing working hours and whatever. You know, it comes back to the same thing. You need to be innovative in your training, not just in technology. And I've said numerous times, whether it's undergraduate or postgraduate, what you need to do is to improve the quality of the unit of training rather than keep thinking about the quantity of the units of training. You know, you can train someone with a better quality hour, structured, evidence-based, than actually telling them you need to do 10 or 15 hours in the subject matter. So we need to be creative and innovative in the training tools and redesigning curriculum in an attempt to improve the quality of that hour of training. And I think there's plenty of scope in improving the quality of an hour of training in all aspects of medical training, whether that is undergraduate or postgraduate surgical training.
Finally, how do you see the future of surgery over the forthcoming decade? What would you think will be the key to advancing healthcare provision in the future?
Surgery has always been very exciting and continue to be very, very exciting. I think the nature and the burden of disease will change. I think we're really operating on patients at the moment that we wouldn't have considered operating on 10 or 15 years ago. It's not uncommon that you end up operating on someone in their, mid-80s with a number of comorbidities. So the demand is changing, and we need to be able to manage that change in nature of disease and the demand that comes with it as a result of the aging population. And at the same time, we need to be absolutely clear and engaging when there is an innovation that could be destructive in terms of whatever we did in the past will be gone. And peptic ulcer disease would have been one good example. There are numerous technologies that will come through, and we may not be aware of them. And I think we need to be absolutely robust in the analysis of that innovation and the uptake of that innovation, as long as it generates value, and adopt that in our clinical practice. Otherwise, surgery will not survive if we're not really in the forefront of innovation.
Professor Darzi, it's been a pleasure talking to you today. Thank you very much.
Thank you.